I think the number one issue is how do we use technology in a constructive, affirmative, and equitable way in order to enable physicians and other healthcare providers to get back to the very core elements of our profession, and that is providing meaningful, engaged care with patients, to get physicians back in contact with, interacting with, caring for the patients that entrust their lives to them. I think we need to start studying and thinking about how medical education can and should be transformed because we have so much greater and timely access to information in ways that we never had before.
This is Second Opinion. I'm Christina Farr.
I'm Zenooz. And I'm Luba Greenwood.
Welcome to the pod, where each week we navigate what's really going on in healthcare through strikingly candid conversations with the entrepreneurs and investors leading the charge. As your co-hosts, we promise to bring the perspective of a former journalist and investor, a doctor, a lawyer, immersed in the future of medicine with life sciences and digital health.
And we're here to sift the signal from the noise in all of these conversations. Thanks for joining us. Let's dive in. Make sure you stick around at the end of the interview for our debrief.
All right. Well, hello, everyone. Today, hi, Ash. And
Hello.
Chrissy's going to be here in a minute. Hello, Dr. Lloyd Minor. It is so wonderful to have you on our program. Before we dig in, we have lots and lots of questions for you. You know, we often on this podcast talk about tech and we talk about healthcare, and we have Ash Zenooz, who's a physician, and she provides us with that perspective. And, you know, we always wonder, gosh, you know, what do physicians think? How is this going to be implemented? We have so many CEOs that have dreamy ideas for all sorts of digital health solutions, and they think those are going to be immediately implemented by healthcare systems and by physicians as well. And we all often wonder, is that really going to work? So super excited to have you on our program. Just for our listeners, very quickly as background, you're the Dean of Stanford School of Medicine, and you really are truly an expert on AI and medicine. You don't just practice that, but you also write books about it and also have had the pleasure of reading also your thoughts on this in places like the Wall Street Journal and Bloomberg most recently. What's also exciting, we'd love to talk today about your involvement, and you're now co-leading what's called Raise Health, which stands for Responsible AI for Safe and Equitable Health, that you've started and leading with Dr. Fei-Fei Li, who herself is the godmother of AI. So we'd love to learn about that. And really just also for our listeners, just to remind them, you know, Stanford School of Medicine is about $13 billion health enterprise. It is the medical school, but it's also Stanford Healthcare and also the Stanford Medicine Children's Health. So very excited to have you on our program, and welcome.
Well, thank you so much, Luba. It's wonderful to be here with you and Ash and Christina today. Thank you.
Excellent. Hi, Chrissy.
Hello. Sorry about that. I had some IT issues, but I'm very excited to be here. Did we already ask, are you comfortable with Dr. Minor, or do you prefer Lloyd?
Lloyd is great, Chrissy. Thank you.
Okay, we'll go with Lloyd. Well, we really appreciate having you here, and there's just so much to talk about today. So do you mind, ladies, if I kick things off with a question?
Yeah, please do. I have so many questions too. So we're going to try not to speak over each other.
It's always inevitable whenever we do one of these pods. But I think for me, what's really been on my mind is just thinking about all the labor issues that we see today. And every time I speak with health system executive friends, they say this is the number one issue that I'm facing. And we can't overstate enough just how big of a problem it is, particularly as we look at the future. More aging adults, more complex conditions. If anything, it's getting worse, and we do not have enough clinicians to kind of meet the needs that we see today, let alone going forward. So would love to hear from you about, you know, as you look at this crisis that's unfolding, what do you see as being the number one most important solution that we could potentially bring to bear? And I know there are lots of different interesting tools out there and ideas out there and philosophies, but just cutting through all the noise, like what do you see as the number one intervention that we should all be paying attention to?
Well, thank you, Chrissy. And it's a real pleasure to be here with you on the podcast today. I think the number one issue is how do we use technology in a constructive, affirmative, and equitable way in order to enable physicians and other healthcare providers to get back to the very core elements of our profession, and that is providing meaningful, engaged care with patients, to get physicians back in contact with, interacting with, caring for the patients that entrust their lives to them. A lot of the introduction of technology into healthcare over the past, say, 15 years, it's certainly improved many aspects of healthcare. I remember so many sleepless nights as a resident going around the hospital trying to find films for the next morning's surgeries, or trying to locate charts that had been misplaced in the record room. It's fortunate that all that has gone away now that we have electronic health records, and increasingly those health records are becoming more portable so that even a patient who's not cared for in a particular hospital, we can get their records quickly and accurately. However, the introduction of electronic medical records and other technology enablers in healthcare delivery have all too often separated physicians and other healthcare providers from their patients. How many times have we had the frustration of visiting a physician healthcare provider, and the first thing that they start to do is type into the electronic medical record? The alternative being, at the end of the day, and sometimes this happens even when they're typing into the record at the time of the patient encounter, at the end of the day, spending 2 or 3 additional hours with documentation, a major cause of burnout in physician and other healthcare providers. Now, with ambient AI being more and more commonly used, there can be a note documenting that clinical encounter prepared during the encounter and reviewed by the provider and the patient before the patient ever leaves the exam room. That's so liberating because it enables the physician to really focus on the interaction with the patient and not think about all the extraneous things associated with keeping accurate documentation, which is so critically important. So to get back to your question, Chrissy, I think addressing the needs in healthcare today for more providers directly engaged with patients, I think AI has the potential to do that by liberating providers from some of the shackles that technology has inadvertently imposed in the past, and also by attracting even more people to the profession, because most people are attracted to healthcare because they want to do something with and for patients. And having technology that enables and facilitates that is going to make the professions even more attractive.
Lloyd, I think that's absolutely right. There have been so many rapid advancements in technology. You're right about that. And you're in the heart of Silicon Valley, where, I would say is like the heart of startup culture in so many ways. I think we're at a point now where we need to rethink how we deliver care, right? With all of this technology around us. How is Stanford Medical School specifically thinking about this, and how are you keeping up with these changes? And, how are you as the dean thinking about the next generation of clinicians, and are they ready to navigate these changes in this landscape? What are the skills they need, and how are you incorporating this into medical education, residency training, et cetera?
Thanks, Ash. That's a great question. I think, first of all, let's talk about how we're thinking about today, what we're doing today, and rolling out the technology into our delivery system. And then let's talk about some very early ideas about how AI and other related technologies may transform medical education, and the way we all keep ourselves informed about our practices and about the latest advances. First, on how we're deploying these technologies today, we've invested a lot in a more user-friendly front end to our electronic health record. We're an Epic system, both on the adult and the children's side, and making sure that there's a user-friendly interface that resembles the apps that we so commonly use if we're ordering something or if we're doing financial transactions. We've really invested a lot in making sure that patients can interact seamlessly, accurately, and at any time they want with their electronic health record and with us as a delivery system. And that work will continue, and those investments will continue in the future, because having a technology interface that's easy to understand, easy to use, and timely is absolutely critical in terms of making the delivery of care more efficient. Other ways that we're implementing technology in our delivery system, of course, with regard to imaging studies where we use AI assistance in the interpretation of, for example, coronary artery imaging to get a coronary calcium score, in extending the eyes of trained radiologists to identify, for example, very small aneurysms from an MRI or other brain imaging scan. So there are a lot of different ways medical imaging wise, where AI is being deployed. Also, in the early stages, how we deploy AI in the interpretation of pathology slides, which I think has a tremendous potential moving forward. So those are some of the things that are going on the ground today, in addition to, as I mentioned earlier, the use of ambient AI in order to prepare documentation from an encounter between a physician and other healthcare provider and a patient. Now, let's turn next to the area of medical education, which I think is fascinating and has been less explored than your podcast, and each of you has written extensively about the applications today and in the future of AI in healthcare, as well as in life sciences and drug discovery and other areas. What's received comparatively less attention is the impact of AI on how we train physicians, how we train others in the healthcare workforce, and also how we, each of us, maintain our skills and our competencies moving forward. And it's going to be interesting to see how this evolves. Medical education has in the past been large. It's like learning a new language or multiple languages, and then learning how to problem solve in that new language, because you have to have a base of knowledge in order to be able to look at a patient, look at an imaging study, put everything together and come up with an assessment of what the diagnosis is, and then some meaningful treatment options. In the past, people have done that in their heads. Now, increasingly, both through information we access through the internet or other portals on the web, or the use of generative AI, we're able to get a lot of knowledge at our fingertips, oftentimes much more up to date and accurate than the way we would be able to do just from a simple internet search or from our baseline knowledge. Now, for sure, with regard to generative AI, we still have to be concerned about hallucinations and the fact that we don't always know when we're getting something that is really accurate and spot on, or something that may represent a random association that even an AI expert couldn't exactly explain how the response was developed by the generative AI model. But those hallucinations continue to get less and continue to be refined as the models get updated constantly. So there is a question here about, well, what's the working knowledge of information that a physician needs to have? I think that's an open question, but I would offer this interesting analogy. I recently had a meeting with a person who's a real technology leader and investor here in Silicon Valley, and we were talking about how generative AI and foundation models is transforming the way software coding is done. And what he pointed out is that the biggest incremental increase in productivity in software design today is the use of generative AI by the very top, most innovative programmers. For them, the productivity introduced by using foundation models to generate code is many multiples of what their productivity was before. For software engineers working more with the routine maintenance of software and incremental development of software, the benefit of generative AI is noticeable. It's maybe 20% increase in productivity or something of that nature, but it's not the quantum leap that one sees at the end, at the edges, where the people that are really, really driving software innovation. And I don't know that analogy is going to apply in healthcare. It very well may not. But I think we need to start studying and thinking about how medical education can and should be transformed, because we have so much greater and timely access to information in ways that we never had before.
It's a great point, and I think that analogy applies very well. And I've had similar conversations, and there's always a question. Well, are some of those jobs of the routine maintenance software engineers going to just go away potentially, or you will require less of them? Because a lot of that work is going to be able to be done by AI. And so the same question everybody always asks, well, are physicians going to be replaced by AI? And I think we all know the answer is no. But are there any particular specialties that you think? I mean, radiology is the most obvious
I was
one.
going to say, I'm a
Yes,
radiologist.
I know. That's why.
So.
But outside of radiology, I mean, is there? Could there be some specialties, and maybe while you're doing your education in medical school, perhaps you do less of that, and you think that there are going to be specialties and more demand?
It's a great point. And as Ash, I'm certain, is aware, several years ago at the RSNA, the large radiology meeting, a very famous technology expert gave a keynote talk in which he said, oh, radiologists, there just won't be a need for radiologists a decade from now. I absolutely think that's not true. And I think when he said it, it was probably tongue in cheek. I think in the future, there are going to be radiologists who use AI, and those who don't use AI probably will not continue to be in the mainstream of practice. But the AI is going to be accessible in ways that everyone will want to learn how to use it responsibly because it extends their productivity. It enables them to do other things. I don't think for a moment that radiologists are going away. I do think that the deployment of AI will enable radiologists, for example, to interact more with physicians who are regularly seeing patients, to partner with those patient-facing specialties to understand, well, maybe this is the best imaging study for this patient, not that imaging study. And they'll be liberated from spending countless hours, over a computer screen reading images to be able to interact more broadly with the delivery system. I also think it's going to be a long, long time before we have an interpretation of any imaging study that's generated exclusively by AI and not had human eyes look at that imaging study before the report is finalized. Certainly true that for many imaging studies, probably even more in the future, that an AI-assisted reading is more likely to pick up on subtle findings that may have clinical significance than a reading that's done by even the most skilled radiologists without AI assistance. And that's why I say I think in the future, pretty much all radiologists are going to be conversant with and view AI as an indispensable tool, just as today, we don't have film anymore in radiology by and large. We're looking at images on computer screens, and all of our radiologists have learned to embrace that. First of all, it's much more flexible. You can expand images, you can rotate images. It's hard to do that with a film unless you're moving it around, and it's in 2 dimensions. So I'm still very enthusiastic about radiology as a field. I'm really proud of the work that our radiology department is doing here in pioneering these advances and rolling them out into our delivery system. And I think that'll be true across the board. I do think that there will be some shift in the roles of healthcare providers, but the shifts will be in a way that makes the work that healthcare providers do at all ends of the spectrum, at all parts of the spectrum of healthcare delivery, will make that work more meaningful, more fulfilling, and more attractive to the workforce in the future.
Let me get a quick question, just follow up on that. And it's probably even more so the case at Stanford and Silicon Valley where you are, is that you have to compete for the best and the brightest with many other exciting opportunities that the best and the brightest can do. If I had to guess, probably 40 years ago, 30 years ago, they would go into Stanford Medical School, but now there are lots of other possibilities. And then they hear, gosh, not only now I have to do even less. I was very creative and innovative, and now I'm going to go to medical school and I have to be augmented with some AI. What do you say to that? I mean, I really am thinking, I have 2 daughters that are interested in the field, but they also love computational biology and other areas. How do you get the best and brightest to say this is what you should do?
It's a great question, Luba. And, for this entering class of medical students that just started last month, the entering class of 2024, we had almost 9,000 applicants for 90 positions. I just got an update last week from our admissions office, it looks like we'll be at over 10,000 applicants this year. We continue, and of course that's true for all medical schools in the United States. We continue to attract just incredible young people who want to go into medicine. I think you mentioned your children. I think that having dually lingual healthcare providers in the future, or maybe it's more than just two languages, but having healthcare providers and physicians who are deeply immersed in not only knowing how to use technology, but understanding how technology is developed and actually contributing to that development, in addition to providing care to patients and understanding the medical world. I think there's this huge need for physicians who are trained in that way and who have that mindset. It's certainly an area of focus for us here in our training programs to provide students who come in with the background and who want to pursue in-depth training in computer science as well as in medicine to enable them to do that. I think there's going to be a place in the House of Medicine for people with multiple different skills and abilities. And the future of the field will be defined by having experts, people who are experts in more than one area related to healthcare and biomedicine, and making sure that they're able to work together synergistically in systems like ours and others.
And then one of the issues that I think, relates to this topic of just how do we get more people into medical school is not only that, but it's how do we get more people into medical school, and then on the other end, picking pediatrics and picking infectious disease and picking OBGYN, endocrinology, any of these. I mean, look at these really important fields and look at salary data. These are not the best compensated, especially relative to surgeons. It's crazy to me because we talk until we're blue in the face about prevention and longitudinal care, and if we don't invest in those specialties, then I don't understand how we get there. Not to mention countless folks are telling me like we're having a crisis where literally no one wants to go into some of these programs. And so the residency programs are just, currently open. So this is a big problem. It relates to like so many different things that I don't know that you and I can solve on this pod, although we'd love to think we could. But how do we get people just practically to want to be in some of these fields?
Chrissy, I think we do it in a number of different ways. One is that the people in the fields play a huge role in attracting the next generation. And you mentioned pediatrics, but some of those dedicated physicians I've worked with here at Stanford, even before coming to Stanford, are physicians who dedicate their lives to taking care of children and making sure that their practices, that their professional lives are fulfilling and that they have a balance between their professional and their personal lives is something that we take very seriously in our physician workforce. We were the first academic medical center way back like 8 years ago to establish an office and an officer, a recruited Tate Shanafelt, focused initially on physician well-being, now on the well-being of our healthcare and biomedical workforce. And we've devoted lots of resources to enable Tate to build programs that assist our workforce in a variety of different needs, including looking at things like how do we make our work environment more friendly to, for example, to new mothers that are coming back in the workforce by having lactation facilities that are readily available in the workplace where women don't have to be going off-site or to a remote part of the workplace in order to have a lactation facility. So there are small things, there are bigger things that you mentioned, Chrissy. That is, how do we, society, remunerate and pay people at various different specialties? I think that's a broader conversation about how we begin to transform our healthcare system in America from being a great sick care system into a system that's really promoting health by emphasizing much more on predicting and preventing disease, as well as in treating complex diseases when they occur, which has historically been the focus in the area of unique excellence of the U.S. healthcare delivery system. And let me mention one other point about your very appropriate question about how do we train more physicians, and in particular, more physicians who are going to enter primary care related specialties. I've had the privilege over the past roughly 3 years of working with Alice Walton in Bentonville, Arkansas, in helping Alice establish a new medical school, which she is establishing and funding fully from scratch in Bentonville, the Alice Walton School of Medicine. I'm the board chair for that medical school, which is a nonprofit, and we're going through the preliminary accreditation process now with the LCME. We have a wonderful inaugural dean, Dr. Sharmila Mahija, and this medical school really is going to be focused on training physicians who will be equipped and who will want to practice in the heartland. From day one, it will emphasize the interaction of physicians and other healthcare professionals with the community. There'll be a federally qualified healthcare delivery center on the first floor of the medical school building, which is now being constructed in Bentonville. We need to think about models like this, and certainly the Alice Walton School of Medicine, we hope, will pioneer the curriculum and the ways that we train physicians to meet the unique needs and opportunities in the heartland of America. But we need to focus more intentionality across the board in medicine on the needs of the physician workforce for the future and how we provide for those needs through our educational systems.
I love that, because one of the things you mentioned in your Wall Street Journal article is about, at some point enabling a physician to look at a skin lesion and through AI have an understanding and ability to diagnose, is this something that is cancerous or not, and having those tools that are available to doctors in rural areas. I love that, because in a sense, are you also trying to, for this new medical school, thinking about some of those tools that can be developed and utilized, and teaching about those tools so that they can be deployed more easily to those physicians?
Absolutely. One of the things that Alice Walton has a keen interest in is innovation broadly in the United States, and innovation in the heartland. And there are a lot of things we're thinking about in the context of both the Alice Walton School of Medicine and an associated innovation ecosystem that we hope will be established around the School of Medicine in Bentonville that will do exactly that. And we're pleased that we have a number of partnerships between Stanford University and Stanford Medicine and the Alice Walton School and other enterprises in Bentonville now. And we're hoping that those will deepen and be expanded even further in the future.
Can I quickly jump in and ask, is tuition going to be free at this new school? Can you tell us?
The plan initially is, yes, that it will be tuition free, at least during the initial years of the medical school.
That's cool. Reminds me a little bit of growing up in the UK, and I had my best friend went to medical school, and you guys will be a little bit physically ill when you hear about how much it costs, but it was at the time £1,000 a year, which is about $1,500 a year. And that always struck me as like, one of the reasons for our problems here in the States, because people have a lot of debt coming out of medical school. And I'm in my kind of mid to late 30s. I have friends that literally are still training, making less than 40K a year. And so when I bring this topic up with them and I mention, why aren't you going into primary care? That's their response to me. I'm going into surgery because I'm 35 and I haven't made any money. And it's hard to argue with that. Like, I totally understand where they're coming from. So it's a great thing that you're doing this and making it free, because it just gives people, when they don't have debt, gives people more options to be able to kind of follow their passions and their interests, I think.
Yeah, I couldn't agree more, Chrissy. I would say I lived on ramen noodles, 5 for $1 for for a while when the paychecks didn't cover things, and I was a practicing resident. So I think these initiatives, I mean, I applaud you for some of the things you're doing, Dr. Minor. Just to kind of double click on some of that, it's great that we're paying and thinking about these things for medical school, et cetera. But beyond medical school, you've obviously advocated a lot for this reactive to preventative medicine, and you're talking about it. But the healthcare system is deeply entrenched when it comes to incentives, and it favors short-term treatments, and payment models are built around these short-term treatments. Insurance is built to sort of cover this for many reasons. What are some strategies that you're exploring, in all the work that you're doing today to drive change and help sort of move us towards the preventative care model?
Well, a few things, Ash, that that I think we can do and that we are doing and that are very, very well aligned with our mission. First, we established a Department of Health Policy. It's the newest department in the Stanford School of Medicine, just a little over 2 years old. And we've recruited into that department premier health economists. The department chair, Doug Owens, is a nationally recognized expert in analysis of primary care and preventative care. He chaired the National Prevention Task Force for several years. And he's an economist who does, detailed analysis of cost effectiveness and quality of life and life extension associated with various preventative strategies. I think there's a strong role for us, Stanford, both in what we're doing in health policy. We have a Department of Epidemiology, really to lead the academic work, the research that informs the development of responsible policy. That we can do that, we should do that in an unbiased, focused way on getting the best factual information, the best unbiased analyses of various different models. And that information then can be used by, as it has been, by the people who are developing policies to address some of the issues that you very appropriately recognized. I think on a national scale, what the U.S. government has done with Medicare Advantage, of course, offers an initial step in that direction. That is to have more risk-bearing or risk-sharing contracts for Medicare Advantage organizations, to offer additional options for Medicare recipients. And as Medicare pioneers some of these innovations, other insurers start to follow as well. Finally, one thing that definitely we are doing and is also very much aligned with our mission is a lot of biomedical research has led to advances in the treatment of the most complex diseases. Certainly in my career, we've seen more advances in the treatment of cancer and more improvements in the outcome associated with cancer treatments over the past decade than we'd seen in the past, say, 20 or 30 years, where there have been a lot of great oncology research going on, but it had not translated into any fundamental advances in patient care until we got checkpoint inhibitors and then cell and gene therapies and then antibody drug conjugates and a whole host tumor infiltrating lymphocytes. We could go on and on with the advances. Now, those today are by and large, at least the innovation and the rollout and the clinical trials are being done at academic centers, but they will extend more broadly. Just as checkpoint inhibitors are now available to any oncologist and when they're indicated to any patient in the country. And I think that innovation that has driven advances in oncology is also going to drive innovations in early diagnosis and even innovations in designing preventative strategies based upon each of our known predilections for disease so that each of us is able to keep ourselves healthy in ways that we haven't been able to do in the past. So those are some of the things I think we, Stanford, can do to impact this problem. Certainly you're correct that if you were designing the U.S. healthcare delivery system from scratch, I doubt anyone would design it in the way that we have it today. But we do have a system that for the most complex diseases, when patients have access to care, there's no question in my mind that we're doing the best job of providing that care. But we're really focused on sick care. We're not focused on keeping people healthy. And also in parallel with what I just talked about, we in the United States have to do a better job in addressing the social, behavioral, and environmental determinants of health that we know account for the majority of shorter life expectancy and decline in the quality of life in our country.
So, I really appreciate that, Lloyd. I want to take us away from, you've been at the forefront, at the leadership forefront, really on care delivery, in your specialty, on bringing technology. But I want to take us back to COVID-19 pandemic, where everything was super chaotic, and talk about academic leadership. So, at that time, I felt like academic leadership everywhere faced really unprecedented challenges, and Stanford really was no exception. There were definitely criticisms about suppression of differing opinions at this time, especially around COVID policies. Some academics complained that they weren't given enough space, and there was a lot of discussion. Of course, the retrospectoscope is a lot easier to talk about this, but there were definitely, I thought, discussions on balancing academic freedom and public health priorities. And I think we can learn a lot from what happened during that time. So I'd love to ask you, I'm sure you've reflected on that quite a bit about leading in a crisis. How are you thinking about balancing fostering open debate while you're also thinking about making quick, decisive decisions on behalf of patients and patient care when the stakes are so high and there's so much uncertainty? I'm sure this is not the first time or the last time we're going to see crises come into healthcare.
It's such a great question, and I'm glad you've brought up COVID-19 because I think for many people in America and around the world, COVID-19 is in the back of our memories, in the back of our minds, and for many people, there's an understandable desire just to move on and maybe forget that it ever happened, but not for us in healthcare. And I do want to say a few words about COVID-19, the crisis here, how we managed it. First, I could not be more proud of our people in Stanford Medicine. Crises can either bring out the worst in people and organizations, or it can bring out the best. And I can unequivocally state that for us here at Stanford, it brought out the best in every person who's here. For the people who ran the supply chain that were calling around the world, getting pallets of PPE and then leasing airplanes to, purchase that PPE and then transmit it to us here at Stanford, to the people on the front lines of healthcare delivery that came in, even during those early days where we didn't know where things were going to go. In every case, we followed the guidelines of our local public health authorities in terms of how there were a couple of months early in the pandemic where we pretty much canceled all non-emergent surgeries and other activities on the directives of our public health authorities because we were concerned that we were going to get the same sort of influx of patients that have been seen in Italy or in New York City. But I'm glad you brought up COVID-19 because whereas many people have moved away from it in terms of thinking about it or how it impacted their lives because people have been able to move on, I think for those of us who lived through it and were on the front lines of healthcare during the time, it's still very much on our minds, in our hearts, and in our psyche because it was something that was totally unprecedented. I recall one of our faculty members is a good friend of General James Mattis, who is here at the Hoover Institution. And General Mattis called this faculty member early in the pandemic, say, "How are you doing? Is there anything I can do for you? I've been thinking about you." And they had a conversation. Then General Mattis ended the conversation by saying, "Remember, this is what you trained for." And I could see General Mattis saying that to troops before they're entering battle. The simple fact is none of us in medicine trained for COVID-19. You can argue we should have, and people like Bill Gates and others were telling us that we were going to have a pandemic, and there was some preparation that had gone on, but none of us had really trained, or really how could we have imagined how we could have trained for the very real issues that we were confronting on a minute-to-minute basis. So for us, COVID-19 brought us together as a healthcare system, brought us together and our people in really transformative ways. And I'm not meaning for a moment to de-emphasize the stresses it imposed on people and the fact that those stresses continue to manifest themselves even to this day. But people pulled together, and that was evident in every way.
But I think my focus question, Dr. Minor, is there space for academic freedoms when there are public health crises?
In my view, absolutely. And look, there were people at Stanford, people who are my colleagues, people who I have deep admiration for, who had very differing views. And there are still debates and disputes going on about those views and their manifestations on both sides, both the side of epidemiologists and the side of those who have questioned some of the outcomes and some of the guidelines that epidemiologists developed. As a leader, my responsibility is to make sure that academic freedom and that an environment that lends itself to unfettered inquiry exists here at Stanford. And that means an environment that promotes civil discourse and an environment that encourages people to speak out and to express themselves and for there to be a meaningful debate. Now, how that gets manifested and who sits around the table for the debate and how people express their disagreements, those are all areas for us to talk about collectively, internally, externally, and to work on. But the bedrock of academic freedom and the ability of people to speak out and speak their mind is one that I firmly endorse, one that we at Stanford, from our president to our board of trustees, firmly endorses. We want to have an environment that encourages and nurtures inquiry. And that means, by definition, then, that it has to be an environment that guarantees academic freedom.
Yeah, no, I love it. I just have to say it's anecdotal. A good friend of mine, Dr. Trounce, who's actually head of your, ER and biosecurity at Stanford. She gave me the time of day. She was very practical, probably during COVID, one of the most practical physicians because, we all thought we were going to die. I actually thought already I had sepsis and COVID, and so she was very practical and really helped me. So, it was interesting. I think many physicians actually kind of threw their hands and said, we don't know, we don't know what it is. And she and her team, from what I've heard, really offered practical advice to patients, and calmed them down and, what they can and cannot do. So grateful for that. I know sort of end of one anecdotally, but I have a quick question because I think we're going to wrap this up and have kind of a quick fire questions for you. Mine is, I'm sure, again, a lot of people that we have on this program, and I think this is how I started, have amazing, wonderful solutions that they think that physicians will immediately adopt because they're just so perfect. And physicians have somehow not even thought about those. And then they think they will make all the healthcare super efficient, and they will, by the way, many people don't come from healthcare or medicine or science. And so I'm sure you see a lot of these solutions going your way. What are the ones I would say, when you hear from your innovation office or somebody comes and says, "Ooh, should we deploy this at Stanford? Should we on a trial basis? Is this something that's interesting?" Again, I'm sure you probably hear this, 10 times a day. Which one would perk your interest, one or two? They'd say, "Oh, okay, I'd like to hear more."
Yeah, help me understand the question a little bit more. So these are ideas about
digital health ideas. So something that, you
sure.
can, anything that helping physician to make a diagnosis, anything AI enabled or helping medical note taking, anything like that.
Well, a couple of things that I've learned about and are being used today are a patient that has a very complex medical history, and they come to the ER at 3:00 in the morning to get care, and there's an emergency physician who sees them, and that physician needs a synopsis of a very complicated medical record quickly in order to make decisions about the care. Generative AI can generate that synopsis, as well as, based upon the patient's chief complaints that led them to come to the emergency department, can generate some ideas and thoughts and areas of focus for the emergency physician. That's so liberating. Yes, there's a problem list in the electronic health record, but rarely does that really pull out the information. It's going to be most pertinent to a physician that has to treat an acute problem in a patient that has a host of underlying chronic conditions. That's one tangible application that I think is having huge impact. The other applications in terms of tracking medications and some of the more innovative solutions of, well, are we sure that patients are actually taking their medications? That's a huge area, since we know that particularly with complicated medical conditions like congestive heart failure, a lot of the treatment failures are related to the complexity of the medications, the timing of the administration of the medications, particularly in the outpatient setting. So the more that we can create smart medications, smart pills, but that actually help and that monitoring and that compliance, the better the health of people are going to be. So those are a couple. I think the other thing that we've done here is to in-license a version of the most current version of ChatGPT, in-license it to our system so that, there's a natural concern, and we try to educate our people that you really cannot be entering anything that is patient related into an open large language model, because that information becomes a part of the open large language model and could conceivably lead to the identification of the patient, even if there weren't identifiers put in the query. So we've in-licensed the model where we can put our data in, but our data doesn't go out of our system. And that makes it then possible for people to take entire sections of a medical record and look, well, what is the best medication for these particular genotypic characteristics of this tumor or this condition? So those are a few of the advances that I'm excited about.
And I love it. And by the way, for the listeners, Lloyd and I and all of us have not talked before about this, because literally last week at the end of our episode, this was what we said. We said your first example was where we said that would be the biggest bang for your buck if you can summarize and help the patient basically articulate for themselves and advocate for themselves. And we had an example of them going to a visit in emergency room. So I love that. That is one of your first applications.
So we're going to do a really quick rapid fire round because we have about 2 minutes before we're going to wrap. So we do this with our guests often. You can pick one answer: overhyped, just hyped enough, or underhyped. And I'm going to throw a couple at you. And Luba, Ash, feel free to throw out a few of yours. And just give me an overhyped, or you can, if you want, you can elaborate for a second or two on why you say it's overhyped or just hyped enough. So I'm going to start with value-based care.
Appropriately hyped.
Just hyped enough. Okay. I'm going to go with generative AI.
Appropriately hyped.
I'm going to go with telemedicine.
Underhyped now. I think that we really saw the capacity of telemedicine when we had to use it during COVID-19. And we're still using it here, probably more than most delivery systems, but it's still got enormous potential, particularly, and this is an area coming back to the work we're doing with the Alice Walton School of Medicine, particularly in the heartland where it can be some distance to get to a specialty provider.
Advanced primary care.
Underhyped.
Luba, Ash, any of yours?
How about augmented reality?
Ooh, underhyped in the sense that I haven't thought as much as I probably should about its application in health and healthcare. So something we should explore more.
How about AI-based drug discovery?
Appropriately hyped. We have to see where it goes, but it's definitely something we can and should be doing, and there are really, really good people working on it. So we tend to overestimate what we can accomplish in the short term and underestimate what we can accomplish in the long term. So I hope the applications of AI and drug discovery, people don't get discouraged. This is a hard medicine, pardon the phrase, for investors sometimes to swallow. But I hope that people don't get discouraged, because it is taking longer than we would want for some of these approaches that are tremendously expensive to actually yield a new therapeutic. I think in the end they will, but it's going to take longer than perhaps any of us had thought.
What about consumerism in healthcare?
Underhyped. I think we all need to learn more about our health, our well-being, and how we can proactively engage with our healthcare providers to keep ourselves healthy and to assume the responsibility ourselves for doing that.
Well, thank you. This has been fantastic. I think I probably would have been the one who was saying overhyped almost all of them. So it was good to hear an optimist's view on all of this. And I think we all need it sometimes. So thank you, Dr. Minor or Lloyd, for joining us on this pod. We really enjoyed it, learned a ton. And I just still can't get over the fact that somewhere out there's going to be a free medical school here in the States. So appreciate all the work you're doing there as well. And we'd love to have you back. Would you come back?
Sure, I'd love to. Thank you, Chrissy. It's great to see all of you again. And thank you for the great work you're doing.
Thank you. Thank you so much. Hello, ladies. So what do we think? That was great. I learned a lot. It's always nice, I think, to have the perspective of well, not just a physician, but also somebody that is leading both a medical school and a healthcare system, and is also very knowledgeable on artificial intelligence and its actual applications and understanding of how it's deployed, who is using it, who's not using it, and where you're going to get the biggest bang for your buck. So I thought that this was a great discussion. What do you think?
Yeah, Stanford's been in my backyard for as long as I've lived in the Bay Area, for the last almost 2 decades. And, I've always respected Lloyd Minor. He's been at the forefront of bringing industry and academia together and encouraging, open discussions, even if it's closed door discussions, open, honest discussions. So really appreciated having him on. I think they got pushed quite a bit during the COVID-19 pandemic because of all of the pushback that they got on academic freedoms. But, at least in my opinion, I think Dr. Minor's done a fantastic job on pushing for academic freedoms. And really, it's always easy to look back and criticize. But in the moment, I thought Stanford did a fantastic job in leading during crises from my vantage point. And he's done a great job in terms of leadership in bringing, tech into healthcare, having these discussions, medical training, et cetera. So I loved having him on.
Yeah, I agree. I think a few things that I would love to kind of press him on a bit more when we have him back. As you know, not as much like buying into the AI hype. I think there's definitely applications, but I would love to hear a bit more about where he perceives the risks and what he's doing to his clinicians to withstand some of those risks, including, a lot of the stuff around hallucinations and so forth. And then there's also complexities around how to roll out some of this technology into hospitals. Like, these licenses are really expensive. So how are you deciding who to partner with? Is it a startup? Is it Microsoft because you know them and you work with them before? So I think those questions are really top of mind for me. And then also to probe him a bit more on, we talked about the labor shortages, and I think he made some good points about just what do we need to do to get people into medicine in the future. But there are limited numbers of seats. Like, you can't just dramatically expand overnight the numbers of people that we're training. It's like the taxi medallion system. So, would want to push him more on that. And then what are ways in which we can get people access to medical knowledge without getting them one-on-one in front of a physician? And I think it's really interesting what certain companies, like I advise a company called Rune, and what they're trying to do with just getting the best Stanford trained doctors in the world out there answering really common questions about certain diseases, so that they don't necessarily have to have a physician repeating, over and over again ad nauseum the same information to their patients. So I think we need to think creatively about how to scale physicians, and that would be an interesting area to ask him kind of what he thinks, because I don't see this crisis as going away, and I don't think that more training is necessarily going to solve it anytime soon.
Yeah, I mean, it's interesting. I thought Lloyd was fantastic. We don't often see that many deans of medical schools being this articulate and knowledgeable about digital health solutions and artificial intelligence, and not just articulate on the applications, but actually having the health system and the hospitals accept and use those applications. So they don't just talk about it, they actually use them. So such as note taking and others. So I actually hope that this discussion encourages many other deans of medical schools and heads of health systems to look into the digital solutions, look into what AI can do, because I know that we talk, yes, of course, there's hype, but there is also a lot of already deployment of artificial and digital health solutions in the first of all, medical school system, but also healthcare systems that have translated into better outcomes for patients, into less burnout for physicians. And Stanford seems to embrace it and be a leader in those and testing them out, seeing what works, seeing what doesn't. I hope that other institutes and health systems do the same. I really do. I just don't see, many are very conservative, very skeptical. It's easy to be a skeptic. If you're a skeptic, nothing gets done. But if you're out there and implementing, and as long as it's done ethically and safely, and Stanford seems to have a whole basically group, an initiative that makes sure that there is equitable, safe delivery of AI solutions and digital solutions. I just hope to see a lot more of it, truthfully, in not just the US healthcare system, but abroad as well. I think we can learn a lot here.
Yeah, they're under pressure. I mean, if you're the hospital system that's literally in the heart of Silicon Valley, you got to be on it. You could not be yesterday's healthcare. So yeah, he was definitely a good one to get to talk to about anything related to kind of healthcare and technology. Glad to have him on.
Yeah. Well, that's great. I guess we should have more Silicon Valley people on this program. I don't know if she's looking like she's not believing this.
No, I love Silicon Valley people. I just moved away from Silicon Valley, so I want to see a lot more of them.
Also, just love Silicon Valley. That's a topic for another day. Maybe Luba needs to move to Silicon Valley.
Yeah. I'm enjoying my San Diego time here. But, the other thing I would want to ask him we didn't get to are sort of the allied specialties around clinicians, how things are impacting those specialties like physician extenders, right? Is AI helping accelerate significantly? And what changes are they making in terms of models of care, bringing in tech into those fields? I'd love to talk more about that with him.
Yeah, and another thing, we can also talk more about augmentation and virtual reality and augmented reality. I mean, one of the applications that I've seen here, I'm not sure if they made it to Silicon Valley yet, but a lot of training of surgeons, for example, neurosurgeons with virtual and augmented reality tools, which is very exciting. I mean, from my understanding, it's shaving off years of training that you need to be a neurosurgeon, especially one that removes tumors from the brain. So something that could be, again, more accessible in other places and where the training can potentially be faster so that you open up more seats and train more people in some of these life-saving surgeries, which right now you can do in a very limited amount of hospitals and places. So those skills are really, they're hard to find and they're expensive.
Ladies, I got to jump.
All right.
It was good to see everyone.
Good to see you all.
Thank you. See you next week.
See you next week.
Ciao.
Thanks for tuning in to Second Opinion. Share it with colleagues and friends and message us to let us know what topics you want to discuss on the podcast. If you want to support the show, the best ways are to leave a review wherever you're listening and make sure you are subscribed. And check out Christina's Second Opinion newsletter on Beehive. A link to subscribe is in the episode description. Second Opinion is part of Turpentine, the podcast network behind Turpentine VC, Age of Miracles, and more shows for experts by experts in tech.